12 noon, so let's make a start. Welcome everyone to the 6th annual community engagement session for the Hazelwood Health Study. We have adopted this format because of the COVID-19 restrictions. Until the last few days, it wasn't even possible for those of us based in Melbourne to visit the Latrobe Valley. But hopefully, as restrictions are lifted, we will be able to engage more fully. However, I imagine that many of you are very familiar with Zoom by now, and there will be provision at the end for people to ask questions of the presenters and other members of the research team who are participating as panelists. For those of you who maybe have not used Zoom a lot, you will find a Q&A box down the bottom. So if you would like to ask a question, please click on that box and then type your question. And that session will be chaired by Judy Walker, who probably needs no introduction, but I shall give her one presently. So without further ado, let's make a start and have a look at the program. So there will be presentations from the various research streams. This isn't a single study, it's actually a very complex program of research. And in turn, we'll have reports from the respiratory stream, the early life follow-up stream, the Hazelinks stream, which makes use of routinely collected health data, the community wellbeing stream, the psychological impact stream. We'll then have some discussions about local outcomes from the study affecting policy and practice in the Latrobe Valley and Gippsland more widely. And I'll then hand over to Judy to moderate the question and answer session. So at that point, I'd like to introduce the lead for the respiratory stream, Bridget Borg, who's the head scientist in the lung function laboratory at the Alfred. So over to you, Bridget.
Thank you, Michael. Next slide, thanks. So we had hoped to be able to conduct the second round of clinical assessments for the adult respiratory stream in 2020, but unfortunately COVID-19 intervened. So instead this year we've spent the year doing further data analysis from the first round of clinical assessments. Next slide. So just to refresh your memories about the respiratory stream clinical assessments, they were conducted in Morwell and Sale in late 2017 and early 2018. And we had 339 Morwell residents and 170 Sale residents participate in clinical assessment of their lung health. And these participants had been invited to participate in the respiratory stream study as a result of having participated in the adult survey that was conducted in 2016 and 2017. Next slide. The first study that we undertook was to understand the effect of mine fire smoke on participants with asthma, which was a subset of about 230 of the respiratory stream participants. We found that when Morwell adults, who were those who had been exposed to mine fire smoke, were compared to Sale adults, those not exposed to mine fire smoke, there was evidence that adults with asthma from Morwell had poorer asthma control than their counterparts in Sale. We did, however, find no difference between groups in asthma-related symptoms, asthma severity, lung function measured by spirometry, or airway inflammation measured by exhaled nitric oxide. The exhaled nitric oxide is a test that measures the components of exhaled breath. The asthma-related symptoms and finding no difference were slightly different to the findings of the adult survey, where there were significant difference seen in asthma-related symptoms between the exposed and non-exposed groups. And this may reflect a smaller participant size and also a different time period at which the symptoms were measured against. Next slide. The second analysis we undertook was to investigate the associations between mine fire smoke exposure and COPD, or chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is a disease that results in persistent obstruction of airflow within the lungs. In other words, the airways are narrowed, and this reduces the ability of a person to be able to blow the air out quickly. To assess for COPD, we performed a test called Spirometry, which measures how fast and how much you can blow out from when you're very full to when you're very empty, and then also how fast you can breathe back in from empty to full. We also used questionnaires to determine participants' symptoms such as cough and chest tightness, and also to record medication use. We found that as exposure to mine fire smoke increased, there was an association with chest tightness and chronic cough 3.5 years after the exposure. In non-smokers, we found that increased mine fire smoke exposure was associated with increased findings of its COPD type pattern on lung function, but we found no relationship in smokers. In smokers, increased mine fire smoke exposure was associated with an increased level of chronic cough. Next slide. The last lot of analysis that I will present today looked for associations between mine fire smoke exposure and a newer lung function test called the forced oscillation technique. The forced oscillation technique measures the stretchiness or stiffness of the lungs. It does this by sending sound waves down the airways while a person breathes on a mouthpiece. And this creates a wobbly type feeling, and we measure what comes back. And this gentleman in this picture here is actually performing this forced oscillation technique. As I said before, this test measures the stretchiness of the lungs. In our analysis, we found that as exposure to mine fire smoke increased, there was a reduction in the stretchiness of the lungs. And this suggests that those who were exposed to more smoke had poorer lung health overall. Importantly, a similar finding was also seen in the early life follow-up stream. So we need to do some more work to better understand this finding. Next slide. So our future plan is to come back and do a second round of testing so that we can get some information about the longer term effects of this mine fire smoke on lung health. So we're in the process of setting up a COVID safe plan to allow us to come back to Morwell and Sale in 2021 to undertake our second round of clinical assessments. And residents of Morwell and Sale who participated in the first round of testing in 2017 and 18 will be invited to participate in this second round. Thank you.
Thanks very much, Bridget. It's now my pleasure to introduce Graham Zosky. Many of you will know Faye Johnston, who was the lead of the early life follow-up stream, but unfortunately Faye's been summoned by the health department to deal with a little problem in Tasmania called COVID-19, which I think is really under control now. In her place, Graham has very capably stepped up. He is Deputy Director of the Menzies Institute in Hobart and Professor of Physiology at the University of Tasmania. So without further ado, Graham, could you bring us up to date on the early life follow-up stream, please?
Thanks very much, Michael. Next slide, please. So just to quickly go over some of our recent activities in the last 12 months, with the delays due to COVID-19, we've primarily been focusing on feeding back results of our studies to the early life follow-up or ELF participants, and doing some planning exercises for future clinics in follow-up to the original ELF study. So in November 2019, we ran our annual ELF thank you party at the Tribe's Indoor Play Centre in Morwell. From all reports, that was well received and well attended. We were hoping to do similar this year, but unfortunately COVID-19 prevented us from being able to do that. In December 2019, not long after the annual thank you party, we published 2 research summaries on the Hazelwood Health Study website as part of the ELF subpage, focusing on results from 2 of our analyses where we focused on exposure to mine fire smoke in unborn children and the likelihood of minor illnesses a few years later. We also examined GP visits and medication use amongst young children. I'll talk a little bit more about the details of those studies in the next slide. In March 2020, oh, sorry, that was the key. Thank you very much, Chantal. That was the key word. Sorry, I got a bit ahead of myself there. In March 2020, we ran a pilot clinic in Hobart. The reason we ran that pilot clinic is in preparation for our next round of clinic visits. We're planning to expand the suite of tests that we use. Bridget covered some of those tests. We're to introduce exhaled nitric oxide and some other tests into our clinic studies to expand on the suite of measures that we have available. We've been feeding back to the ELF participants via a regular newsletter, and the families were invited to attend the Gippsland Air Quality Forum where Associate Professor Faye Johnson was a speaker. Next slide, please, Chantal. So just to summarise the two studies and the key findings from the studies that we published on the Hazelwood Health Study website, which have now been published in the scientific literature. In the first study, we were looking at the effect of mine fire smoke exposure on unborn babies via the mother. In the first study, we assessed the likelihood of being prescribed particular medications in the first year of life. And we did that by accessing publicly available Medicare data and pharmaceutical benefit scheme data, and found that there was an association between the amount of smoke that the mothers were exposed to and the likelihood of their child being prescribed antibiotics in the first year of life. We found no other associations with visits to GP or other common medications that children use in that early life period. In a follow-up study, we examined data from 2 to 4 years after the fire, and to do this, we used monthly diaries collected from 160 children. There were over 2,500 diary entries that we summarised, and we looked at the association between exposure in early life in unborn children to the mine fire smoke and the likelihood of having a doctor diagnosis of cold or flu and the use of a range of medications. And we found that the more smoke that the mother was exposed to, the more likely the children were to have a doctor diagnosis of a cold or a flu 2 to 4 years later. And we found no association with other common childhood conditions such as fever or skin conditions. And collectively, these two studies suggest that exposure to the mine fire smoke might predispose to certain responses in young children characterized by inflammation and upper respiratory tract infections. Next slide, please, Chantal. So our current plans are to get together our procedures for setting up the next follow-up clinic. We're hoping to do that in the first half of next year, provided we can get all our COVID safe plans in place. We're going to measure the lung function. We're going to measure lung function using one of the forced oscillation technique that Bridget described, and we're also going to measure heart function and blood vessel function as we did in the first ELF study. And we're also going to expand our measurement procedures to include measurements of inflammation and allergy. Thanks very much, Michael.
Thanks, Graham. It's great to see almost 50 people participating in this Zoom webinar. And I realised I forgot to introduce myself, just in case any of you don't know who I am. I'm Michael Abramson, and I'm the Principal Investigator for the Hazelwood Health Study. It's now my pleasure to introduce somebody who needs virtually no introduction, and that's Jill Blackman, who's our Senior Project Manager. And Jill's going to show you some of the recent findings from the Hazelinks stream. Over to you, Jill.
Thanks, Michael. So as the Hazelinks stream uses administrative health data sets to track changes in population health over time. So, I was going to say that you can see some of the data sets that we've linked to, but I can't see them on the slide at the moment. Perhaps they're on the next one. Oh no, that's okay. What I'll be talking about today are findings based on data from Ambulance Victoria and data from the National Mortality Database, which is maintained by the Australian Institute of Health and Welfare. But what I thought I would briefly show you is some figures that give you an indication of how we've measured air quality during the mine fire. And early in the study, the CSIRO undertook detailed modelling of the impact of the mine fire smoke plumes on air quality. A major pollutant of interest was PM2.5, which are very fine airborne particles. And as smoke density increases, PM2.5 density increases also. And so this was the measure of smoke exposure used by the study. So figure 1 on this slide shows you all of the geographical locations that experienced higher than usual PM2.5 levels at some point during the mine fire. So all of those areas shown in the map there. We can see that Morwell experienced the highest concentrations of PM2.5 and that the levels were lower further afield. In figure 2 to the right, what we can see are estimates of the daily PM2.5 concentrations in the southern part of Morwell closest to the mine. You can see that the smoke concentrations in that area changed a lot from day to day. The shaded part of the figure represents the first 30 days of the fire, and that's the period of the highest levels of exposure. After that, the fire was relatively well controlled and PM2.5 levels returned very close to usual backgrounds. But I show these to indicate why some of our analysis focuses on the first 30 days of the mine fire, why sometimes we focus on day-to-day changes, and why some of our analysis focuses in on Morwell as well. Next slide, please. I'm going to start with some of our findings from analysis of Ambulance Victoria data. And this first data set contained anonymous ambulance attendance records for all smoke impacted areas from July 2010 to March 2015. And we looked at the pattern of attendances over that almost 5-year period to see whether the pattern changed during the mine fire. And this analysis focused on the first 30 days. We found that there was an overall 15% increase in ambulance call-outs during that 30-day period, and that corresponded to approximately 225 additional attendances. But more specifically, there was a 47% increase in ambulance attendances for respiratory conditions, and that corresponded to approximately 37 additional attendances. When we looked at changes in the daily levels of smoke, we found that increases in smoke concentration levels were followed by increases in respiratory-related ambulance attendances for about a 5-day period. Next slide, please. A second set of data that we analysed this year was identified ambulance data linked to our participants from the 2017 adult survey. And at that time, many of our adult survey participants provided consent for us to retrospectively and prospectively access their Ambulance Victoria records. Those participants also provided time location diaries, which we blended with CSIRO's modelled PM2.5 data, and that gave us an estimate for each participant's smoke exposure level. So using those combined data, what we found was an association between higher PM2.5 exposure levels and increased risk of ambulance attendances over a 3.5-year period after the mine fire. In particular, we saw associations between higher PM2.5 exposure and increased ambulance attendances for respiratory conditions and for cardiovascular conditions over that time. Next slide, please. Hazelinks' most recently reported findings are those based on anonymous national mortality database data for all of the smoke-affected areas. We started with data from the 4.5 years leading up to the fire, and we looked at the patterns of death observed in the smoke-affected areas over that 4.5-year period. We also looked at changes in the age and sex structure of the population and the effects of hot or cold weather and other factors that could have influenced population mortality. Then we used all of that information to estimate what the expected risk of death would have been during the first 30 days of the mine fire and also during the 6-month period after the fire. Next slide, please. When we looked at the first 30 days of the mine fire, the overall risk of death was similar to what we expected. However, when we looked separately at specific causes of death, we found an increase in the risk of injury-related deaths across the Latrobe Valley area during that 30 days. The increased risk of injury-related death was most notable amongst men and people over the age of 80. Across all of the smoke-impacted areas that I showed on the figure earlier, we estimated that there were 11 more injury-related deaths than expected, and 3 of those were in Morwell. We were able to tell that the injury-related deaths during the period were predominantly from unintentional injuries and not intentional self-harm. When we looked at other types of death during the 30-day period, we didn't observe any increases in those. Next slide, please. When we looked at the 6 months after the fire, we found something different. So during that 6 months, the overall risk of death in Morwell was 29%, or about a third higher than expected. We didn't see an increase in mortality in other smoke-affected areas in that 6-month period. When we looked at specific causes of death, however, we do see an increase in cardiovascular-related deaths in the Latrobe Valley, but particularly in Morwell. And by those, I mean deaths from heart or circulatory conditions. Again, men and residents aged 80 years or older were at greatest risk. In total, there were 27 more cardiovascular-related deaths in Morwell than expected for that 6-month period. And 17 of those were from ischemic heart disease, which is also called coronary heart disease. Next slide, please. We've already seen other Hazelwood Health Study research showing adverse effects of the mine fire smoke on respiratory health. In this analysis, we didn't see any increase in respiratory related deaths, but we do have anecdotal evidence to suggest that many people with chronic respiratory conditions who may have been at greatest risk possibly took preventive action, and that might have included leaving the smoky areas, wearing protective masks, or increasing their use of preventive medications or oxygen therapy. And those actions may have saved lives during that time. It is important to note a couple of limitations to the mortality data. Firstly, in regard to the injury-related deaths, it wasn't possible to tell from the data what activities or behaviours led to the injuries that caused the deaths. So we don't really know what people were doing. Secondly, the anonymous data allows the researchers to investigate changes in the pattern of deaths in the community, but not to investigate whether any individual's death was caused by the smoke. Next slide, please. So in terms of findings from Hazelinks from the last year, that's a very brief snapshot. And we do have more detailed technical descriptions of the findings and also lay summaries of the findings on our website. And if you go to the link there and select the findings tab, you'll find those. In terms of future plans for Hazelinks, we already have linked hospital data that is being analysed to investigate the association between smoke exposure and the likelihood of hospital emergency presentations or admissions. And we also have linked cancer data to investigate any association between smoke exposure and the likelihood of a cancer diagnosis. Thank you.
Thanks very much, Jill. I'd now like to call on Dr. Susan Yell from the Federation University to update us on the community wellbeing stream. Over to you, Sue.
Thanks, Michael. Chantel, next slide, please. So in previous years, the community wellbeing stream has been tracking the community's wellbeing and recovery after the mine fire. We're going to keep doing this over the next couple of years, but we are broadening our scope to look at subsequent events. So things like the closure of the Hazelwood mine, also closure of some other large local employers, and the release of Hazelwood Health Study results. We'll also look at initiatives that have taken place that may have had a positive impact on community wellbeing, like the formation of the Latrobe Health Innovation Zone and the Latrobe Health Assembly and the appointment of the Latrobe Health Advocate. Preparations are underway for our Year 6 interviews, which will take place via Zoom for so that we can stay COVID safe, certainly for the rest of this year. We may be able to resume face-to-face interviews in the new year. So we're aiming to have those interviews completed by February next year. And we're going to go and interview community stakeholders and community members to ask them about their perceptions of community wellbeing at this point, to capture the feel of the community and how it talks about itself. We'll also ask them about the factors they think have the most impact on the community's wellbeing and about their individual sense of wellbeing. And that information will be used by the psychological impacts stream and feed into their research program. A major new activity this year has been working on the development of a community wellbeing barometer. And next slide, thanks. So the community wellbeing barometer, the aim of this is to capture changes in community wellbeing and how the community is impacted by significant events. So we've been doing extensive work to identify the components of community wellbeing and have come up with these core areas relating to health, the economy, the environment, services, and social connections. And that last one I think is particularly important. We've also been working on investigating the appropriate data sources to use to track each of those areas. And they'll be taken from publicly available data sources, things like ABS census data. And there are other kind of sources, so we can look at what's already out there. As part of our work on developing the barometer, we've been looking at La Trobe City Council's Health and Wellbeing Plan, Living Well La Trobe 2017 to 2021, and other relevant sources of information, including the Regional Development Victoria Information Portal. And that's to help ensure we don't duplicate work that's already being undertaken, but rather we can think about how best to contribute to existing efforts and complement that work. We'll consult with community stakeholders and community members through our interviews to ensure that the barometer is well suited to capturing the unique place-based aspects of the La Trobe Valley. And next slide. So when we've finalised the components of the barometer, we'll use it to measure changes in community wellbeing. So, for example, before and after the mine fire and in response to other major events, for example, COVID and the major bushfires that we experienced last summer. The mental health and wellbeing follow-up survey that Matthew Carroll will speak about shortly included some questions relating to community wellbeing, and we will be analysing the responses to those questions. We're going to put all these data sources together, so the interviews that we're doing, the data from the barometer and the surveys, to give us a more complete picture of community wellbeing, including what makes this community resilient as well as its areas of vulnerability. And finally, we'll also continue to look at impacts on older people and what we can learn from our elders. An invited book chapter and editorial will be coming out shortly. Age is continuing to be a key factor considered in the analyses arising from the other stream areas, and that includes the mortality findings just released by the Hazelinks stream and the adult survey follow-up completed by the psychological impact stream. Thank you. That's it from me. Happy to take questions later.
Thanks, Sue. And that's a wonderful segue, because just for those of you who maybe aren't using Zoom every day, there's a Q&A box down the bottom. We've already got a few questions, but if you do have questions of any of the presenters or the other panelists who will be introduced shortly, please type into the Q&A box and we will discuss the answers shortly. So I'd now like to introduce someone else who probably needs no introduction. Dr. Matthew Carroll is from the School of Rural Health, and he's the lead of the Psychological Impact stream, and he's also recently stepped up to become the principal co-investigator Gippsland. Over to you, Matthew.
Thank you, Michael. Next slide, please, Chantal. So in terms of recent activities, we've had a lot of time in the past year to really look at analysis of of our existing data collection. And we've had 2 reports that we've released, and there's 2 other analyses that we've focused on. So the first one, you may remember, we had a school study where we surveyed students in grades 3, 5, 7 and 9 in 2015 and 2017. We've done further analysis now looking at the NAPLAN results for those children where we've got the information prior and post, and I'll tell you more about that shortly. And because that was a relatively small number of students, we've now done further analysis, which we're working on, looking at the NAPLAN results for the wider region. So that includes group results for all grades, all schools in Morwell versus the rest of the Latrobe Valley, and then the Wellington region as the control, and that's underway. We've also released findings doing further analysis of the major adult survey, and what we've done here is look in more detail at the other risk factors, so I can tell you more about that one in a tick. And as part of that work, we've got a PhD student, Caitlin, who's doing a project on young people, and she's done some target analysis of the adult survey data, where she's looking at comparing people 18 to 34 with other age groups, and she's been doing some interviews in the last couple of months as well. Next slide. Our main activity in the past year, and we're quite lucky we got it done in time, was we actually did a follow-up to the adult survey, and that ran between December last year and early March this year. And that repeated core measures of the distress. For some reason, my video is not showing up, don't know why. And as well as adding new measures. And there's 713 people participated in the survey, which was more than expected. We think that was because more people responded because it happened to coincide with the major smoke event that we experienced over summer attached to the major bushfires elsewhere in the region. But interestingly, we think that will yield real insights into the impact of a current smoke event on a community that had previously been impacted by the 2014 mine fire. So that should be quite powerful results. This work was completed just prior to COVID-19 becoming a major concern, so provides an important snapshot of the community. Next slide, please. So, as I mentioned, we had some findings that we've released this year. The first one for adults was that analysis of the adult survey data. And we've repeated some of the findings from the original analysis, where we did see that there was a relationship between high levels of exposure and high levels of distress 2.5 years after the event. And that level of distress was moderate across the community, and some people recording very little effect and others reporting high levels. But as I say, the main difference here is that we really looked into the role of other factors like prior mental health, people who've had 2 or more traumatic exposures, the impact of education, level of unemployment, and we actually found that those factors and others were actually related to higher distress. Interestingly, and as Sue said, we're very focused on aging. Age was actually identified as a key factor, but in the opposite direction. It was actually younger people who were more impacted by Hazelwood at the higher levels of exposure. Once you control for chronic health conditions and things like that, older people were less likely to report distress. In fact, they had a flat line across the levels of exposure. And we think that provides really valuable information about vulnerable groups and nuanced information about vulnerable groups who could be targeted in the public health response to a future event. Because in this case, for this sort of outcome, older people were not vulnerable, younger people were, but also people with prior health exposures, prior traumatic events and so on. So that could actually be fed into the public health alerts in future events. Next slide, please. So we also released results from the school study. We'd previously released the findings of our surveys that we did in 2015 and 2017, but we also had permission to link to their NAPLAN data. And we had access to years worth of data prior to the event and post the event. And after controlling for other factors, so we know that there are general differences between schools and between towns in terms of NAPLAN outcomes, we actually found that the more exposed and disrupted Morwell High School actually had lower academic outcomes compared to their peers elsewhere in the valley. We didn't find the same result for younger children in the primary grades at the time of the event, but that's based on a small number of students because it was based on the sample size for the surveys, and then of those, how many of those did we have permission to link NAPLAN? So it was only 303 students. So as I said, we're conducting further analyses now, looking at the average results across those 4 grades, across all the schools in the region compared to the Wellington Shire as a control. And we think that will provide us with much clearer evidence of findings related to NAPLAN and the mine fire exposure. Next slide, please. The future plans, our real effort at the moment is the analysis of the adult survey follow-up that we completed at the beginning of the year. And that first report will be due out soon. That's really looking at the changes between the two rounds of survey, between the one that finished in 2017 and the one that finished this year. So on the core measures of distress and the variables that we already knew about, as I talked about in terms of prior mental health and traumatic exposures and so on. But once we've released that report, we'll move on to do a whole series of other analyses looking at the new measures that we included in the survey. So the things like loneliness and social isolation and so on. And as Sue said, as part of the community wellbeing stream, we've included measures of how people rate their current community wellbeing and how they think community wellbeing has changed over time since the Hazelwood event. And so we can look at the link between that and individual wellbeing. So do people who are experiencing more distress rate their community differently? Do people who are more lonely or isolated rate their community differently? And again, more resilient people. So we can really look at what the links are between individual factors and community wellbeing. We're doing a new survey with the early life follow-up stream that Graham talked about earlier to actually look at the broader parent and family wellbeing outcomes following the Hazelwood event. And that will be done, we're hoping, at the end of next year. And we'll do a further follow-up to the adult survey that we completed at the beginning of the year. So that'll look at longer-term mental health and wellbeing of study participants. And importantly, we'll try and pick a time that doesn't happen to coincide with a major smoke event so that we get a clearer understanding of ongoing Hazelwood outcomes in adults following on from our first and second surveys. Thank you, Michael.
Thanks very much, Matthew. Now, please don't go away. Firstly, I'm going to play Nostradamus and predict that there won't be a major bushfire in East Gippsland in this fire season, but of course there could easily be elsewhere. It's great to see a few questions coming into the Q&A box. Just a reminder for those of you out there who might have questions and don't use Zoom every day, just click on the box and it then opens a little window where you can type your question, and then shortly Judy will direct that to the most appropriate panelist. So the reason I asked Matthew to stay on is that he'll also be talking about the local outcomes from our study. So back to you, Matthew.
Thank you, Michael. And next slide, please. So, as we know, the only reason that the study is here is because the community raised concerns at the time of the mine fire event, and we had the petition of over 20,000 signatures and so on. So we always have to remember why the study's here and that we're continuing to address the concerns that were raised by the community at the time and ongoing. And as you might remember at the time, there was a lot of discussion about the lack of information about the health impacts of extended smoke events because there was simply no research in that space. So they can't say that anymore because there's considerable research in that space over the last few years, including some of the things we've seen over the last 12 months today. So that includes short-term impacts like the increased use of health services and prescribed medications. And I see Tim's asked a question about that, as well as the very recent findings of 11 additional injury-related deaths in the 30 days of the peak mine fire period. We've also seen evidence of longer-term impacts, including the increased distress levels that I've just talked about, reduced lung stretchiness from the respiratory strain, and additional ambulance call-outs, and again, the recent findings of 26 additional cardiovascular-related deaths in the 6 months following the mine fire. So that's told us a lot about the impacts from Hazelwood, but in doing this, we've collected a lot of information regarding the general health of the community. And that includes things like the high proportion of participants with high blood pressure, 37% of whom were undermanaged, and 80% of whom were not managed. And that information has been fed back to the participants and their GPs for them to discuss and hopefully better manage those conditions. Findings with relation to obesity and smoking rates and the link to cardiovascular outcomes. And part of that has been taken up very heavily by the La Trobe Health Assembly, which I'll talk about shortly. The role of other factors, as I just talked about, in terms of age, education, prior mental health, etc., in the development of stress and the potential to target groups in future responses, and the work of the community wellbeing stream in terms of looking at the community concerns regarding lack of disaster planning, need for clear recovery strategies, and the interesting shift over the last few years and focus from health to a broader focus on the future of the community post-cold and so on. So all the information that we find gets fed back, and we work to try and see that it actually gets taken up locally. And I'll just give one example in the next slide, please, Chantel, of the potential of actually having those connections. And that's actually comes from our cardiovascular stream, where a survey on food preferences was included as just one of the aspects of the cardiovascular clinical testing, where we actually tested about 500 people. Those findings on just that one survey were published, and there's a copy of the publication down the bottom corner there, and they were shared with the La Trobe Health Assembly. And EJ and Tanya immediately wrote back and said, "This is great. We're interested to see what our community people are eating. What can we do about it?" And invited multiple stream researchers to actually come and meet with the full assembly virtually, and actually have breakout sessions to actually really drill into the data and how to actually make use of it to encourage healthy eating. And that's actually resulted in an ongoing collaboration with 2 Monash nutrition studies students, I combined those, working with the Assembly to run a series of nutrition workshops with key local partners, and a successful Nutrition Week social media campaign, and a number of other things. I can't believe how much they got done in an 11-week placement. And then that work's also fed into national and local project funding proposals to take the work further, with a real aim on trying to make healthy eating the desirable and easy option. And that's a really challenging thing to do, because you're working on individual choices, but you've got to change things in local government, and you've got to work with the industry, with the supermarkets and so on, to provide healthy eating options and make them more accessible and so on. And Chantel, if you press the next slide button, we should see a picture of Orly and Julia, who did a presentation last week. And I was lucky enough to sit in to actually watch that presentation and be amazed at how much work they've done. And down the bottom corner there, it was just gone now, was a little photo of Tracy, who's really worked so closely with EJ and Tanya from the Assembly to make this happen. So I really, really congratulate you guys on all the work that you've done. And it makes me so enthusiastic about the capacity of the study to connect in locally and actually have an outcome. Okay, thank you, Michael.
Thanks, Matthew. And the Nutrition Project is a really nice example of a spin-off, and I would like to welcome Orly and Julia, who are online, along with their supervisor, Dr. Tracy McCaffrey from Monash. It's now my pleasure to hand over the chair to Judy Walker, who again needs no introduction to any of you. Judy was co-principal investigator Gippsland for the first 5 and a bit years, and she's now an adjunct professor in the School of Rural Health. So I'll invite Judy to moderate the questions and answers and to close the community briefing.
Terrific. Thank you very much, Michael, and it's just lovely to be here today. Look, I'll just start off by introducing you to the additional panelists, because you've obviously met the presenters, but we do have other experts with us as well. So we've got Professor Malcolm Sin, who leads our cancer and mortality stream. We have Associate Professor Yumin Gu, who is the stream lead of Hazelinks. We also have with us Caroline Gayo, who is a research fellow. She's a biostatistician, so all those curly statistical questions that you've got, we'll direct to Caroline. We've got with us Christina Dimitriadis, who is our research officer. And we're really, really happy that we've got Ellen Jane Brown, who is the Executive Officer of the La Trobe Health Assembly, with us, and Tanya Rong, who of course is the chair of the La Trobe Health Assembly. And a particular welcome to Jane Anderson, our health advocate in La Trobe, and very importantly, Carolyn Boothman. Welcome, Carolyn. Carolyn has been the chair and still is the chair of the Hazelwood Community Advisory Committee. So thank you for being with us, panelists. We have got a number of questions in our Q&A box, but I think I'm just going to make a little bit of a comment about Matthew's penultimate slide about the impacts over the past year of what we've been finding in the local community. And I think I'd like to throw this one to Jane, our advocate, La Trobe Health advocate. Matthew did talk about the high proportion of participants with high blood pressure, and quite a large percentage, 37%, were undermanaged and 8% not managed. And I just wonder, Jane, from your perspective as La Trobe Health advocate, what this actually means to you.
Thanks, Judy, and thanks for the invitation to be part of the conversation. I think what's really important that was highlighted in Matthew's presentation is how this information that we're learning from the health study is utilised, and there was the great example of how the Health Assembly is using the nutritional information. So I think similar with this data, it's how we understand it, and then how we can actually use that to inform the improvement of health of people in La Trobe. I think the other key issue and the connection is around the Wellbeing Barometer that Sue Yell spoke about. And it's about all those indicators, how they come together so we can understand the strengths and then also how we can build resilience in the community. So these are key pieces of research that we need to now take back more to the community to understand more broadly from other members of the community, and then consider what are the ways that we can use that information to improve the health and wellbeing, involving the community in the design of those solutions.
Mm-hmm. Thank you. Thank you very much, Jane. We might come back to this particular topic in a little while, but what I'd like to do is actually go to the specific questions that have come through on the Q&A chat, and please continue to post your questions. Now, we do have a couple from Tim Owen. Hi, Tim. So what I'd like to do is just read this question out to begin with. What is the theorized pathway that explains why particulate exposure would lead to changes in use of prescribed antibiotics? Has this outcome been found in other studies of particulate exposure? And do we know anything about the relationship between dose and this outcome? Now, Graham Zosky, could you comment on this, this engagement with Tim, please, because this clearly comes from your presentation.
Sure, Judy, and thanks for a great question, Tim. In terms of the theorised pathway, in recent years, it's becoming increasingly clear from work from my research group and others around the world that there's a strong link between immune changes that happen during pregnancy and immune development in the child. And so from work that we've done, we've shown that particulate exposure, maternal particulate exposure, changes the way the immune system develops in the child in a way that seems to predispose them to respiratory infections in particular. And so the observation that we saw an increased use of antibiotics is in line with the second study where we saw an increased risk of diagnosis of respiratory tract infection. Now, we don't know, of course, whether it specifically increases the risk of getting a bacterial infection and therefore increases the risk of being prescribed antibiotics, or whether it's just difficult to diagnose bacterial infection in young children, and therefore we've got an increased risk of respiratory infection, and therefore the amount of the antibiotic prescription goes up. In terms of the dose and the dose response, it was around a 24% increase in incidence of antibiotic use for a 10 microgram per cubic meter increase in PM concentration. So that's what our study showed.
Thank you, Graham. And of course, Tim, I'm sure that Graham would be happy to continue the conversation after the Zoom session if you want to take that further. But I'm actually going to take the opportunity, because you had another question as well. You were asking, in what ways is the analysis of deaths undertaken different to that done in the mortality stream of the HCMF inquiry? And I think the most appropriate person to comment on this question would be Malcolm Sim. So Malcolm, over to you, please.
Thanks, Judy, and thanks for the question, Tim. Yeah, this is an important question because this was a key finding in the inquiry report. So at that time, the analysis that was done really just looked at occurrence of death. So we've been able to expand on that analysis to look at both underlying and associated causes of death So, you know, our results have provided some more detailed and more robust findings than were presented to the inquiry. We also used a more advanced statistical method because we were able to adjust for a whole range of factors that can influence mortality. So this is things like temperature, seasonality, population structure, and other factors as well. And we also did an analysis looking at surrounding areas as well, because that's a more comparable population than just looking at you know, death structure for the state as a whole. We also had access to a better exposure data through the modelled PM2.5 data, so we're able to get a stronger sense of the association with those different levels. And just lastly, we looked at the exposure 6 months after the event, which didn't happen with the analysis presented to the mine fire. And this is where we found the excess of cardiovascular deaths. So I think this analysis really dug a lot deeper into the mortality data, both at the time of the mine fire, but also in that important 6-month period afterwards.
Yeah, thank you. Thank you so much. I wondered, Michael Abramson, did you want to make any comment about this as well?
Judy, I think Malcolm has dealt with it pretty thoroughly. In the event that Tim has other questions, we'd be happy to deal with them offline.
Thank you. Thank you so much. Let's go now to Eunice Donovan. Eunice has a question, very interesting question. She says, I note and support the focus on age as a factor in community well-being. Is there or has there been any focus on the impacts of well-being of persons with a disability, either those with pre-existing disabilities or those who may have acquired disability? Sue Yell, would you like to make a comment and respond to Eunice, please?
Sure, Judy, and thanks for your question, Eunice. This is a really good one. We haven't specifically in our results so far from the first few years of looking at community wellbeing, disability hasn't emerged as a theme, but I think that when we go out to this next round of interviews, it would be worthwhile making sure that we speak with groups and individuals, including disability groups, and then we can, it would definitely be worthwhile seeing if there is a relationship between disability and what the potential impact that might be on community wellbeing. But I think also there's a relationship there with individual wellbeing, and I don't know if Judy wants to pick that up or throw that to any of the other stream leads. I'm going to handball a little bit on that one, but thank you, Eunice. I think that's a really good contribution that we will take on board.
Thanks, Sue. Actually, I'd like to ask Caroline Gow if she would comment on this, because bear in mind, Caroline has the absolute overview of all the data. She has been immersed in this for the last few years. So Caroline, did you pick up anything in relation to the impacts on persons with a disability?
I think there's a very interesting question. So definitely from looking at a lot of data that we've collected for both the adult survey, which we have got extensive questions on mental health and also physical conditions, as well as the psych follow-up. I think there will be a lot of additional analysis that is currently either underway or we're planning to go down and to look at those factors. I think they're very important to look at the vulnerability of the community from further bushfires and mine fires, and inform of government on who to protect. From our limited results, I think age is a very important factor. We find it out that young people are much more vulnerable, but also people having a current diagnosis of mental health conditions, and they're particularly at risk of further advanced stress and particular post-traumatic symptoms related. And the whole team will continue to look at these matters, and hopefully we'll be able to generate a lot of meaningful results.
Thank you. And again, Eunice, I'm sure if you want to take this further, let us know and we can put you in touch with the appropriate person. I'd like to turn now to Ruth Churchill. Hello, Ruth. Lovely to have you on this Zoom webinar. Ruth, you have a question about the psychological stream next adult survey. You ask, will you be able to differentiate between ongoing impacts from the mine fire and consequences of COVID-19 and restrictions? A very, very important question. Matthew Carroll, this has to go to you.
Thank you, Ruth. Yes, it's an interesting question, and it's always good to know about these things before you design a survey. So when we ran the survey, pardon me, at the beginning of the year, we didn't know that we were about to run it in the midst of a major smoke and bushfire event, so we didn't have questions about the current event. The next round of the survey will most definitely include information about exposure to the smoke from just recently, as well as questions to do with COVID-19 and restrictions and so on. So it's just going to be a matter of what you include in your survey in order to take control of these things. And we're very interested in this additive effect of multiple exposures because we think that's quite important. And that's partly what we're talking about in the analysis that we're currently working on for the survey we've just completed. So great question. And yes, we'll certainly make sure that we can try and actually tease out the different exposures.
Thank you, Matthew. Sue Yell, did you want to add to that at all?
No, Judy, I think I'll leave the field because I'm aware there are other questions coming up. So I'm happy to, yeah, I think Matthew's covered it.
But Sue, your interviews will actually include people's responses to actually talking about COVID-19 and so on. So that will come up.
Yeah, from a qualitative point of view, it most likely will come up, that people will talk about the things that have been impacting their individual wellbeing. And I expect that will be one of them.
I'd actually like to just quickly turn and ask Carolyn Boothman if she wants to make any comments on this, because, you know, this is a really important community issue. So Carolyn, any comments from you?
I think what we're seeing is over so many years, so many different challenging situations facing the people of Morwell and the wider Latrobe Valley area. Yes, we had the mine fire, then we had the closure of Hazelwood, then we've had the bushfires around still, even in East Gippsland, that still does affect us down here. And particularly the mental health and wellbeing of people down here is very much impacted when there's a smoke event like that or when there's planned burns. And now to add COVID-19 and all of the being from home, that's had a major impact again on the psychological wellbeing of people in the area. So it will be interesting to see what the data shows us in the future.
Thank you so much. To our final question, because we're nearly reaching the witching hour, again, back to you, Ruth Churchill. And you've actually asked a question that I had in my little store of additional questions in case nobody was asking anything on the Q&A. And this is around the Community Wellbeing Barometer. And you're asking, do you think the Wellbeing Barometer will lead to a model which could be applied in other communities? Would it be too early to be considering other applications? And Sue, that has to be you.
Thanks, Ruth. And yeah, we are definitely hoping that when we develop the model, that it will be something that could be transferred and used in other communities. I think there are other communities facing many of similar challenges, even though the Latrobe Valley is in many ways quite distinctive in what it's experienced. But yes, I think we would like that to be a model that people can pick up and run with. And, you know, right down to different community organisations, whether they're in this region or further afield.
Okay, thank you very much. I think it is time now to wind up. I want to say a really warm thank you to everybody who has participated on this webinar. I wish I could see you all, but I know you're there, and it's wonderful to have had such a great response. A particular thanks to our panelists. I know there weren't questions for all of you, but I know that you are willing and available should anybody have further questions that are stimulated by the discussion and particularly by the presentations that we've had today. So thank you very, very much. Just you've got the contact details through Chantel. So please just send any further questions through. Thank you all very much, and particular thanks to the presenters, and even more particular thanks to Chantel Allgood and Matthew Carroll, who have spent quite a bit of time making sure that we have been able to do this webinar today, and that it has been extremely, in my opinion, professional, and I have been absolutely delighted to be part of it. So thank you all. Take care, keep safe, and we'll see you obviously next year at the next annual briefing session, if not before. Thank you.
Thanks,
Goodbye.
Judy. Goodbye to everyone.